seniors and colleagues. So I will be presenting the case on the posterior dislocation of the shoulder. So patient came, a 73-year-old male with a history of syncopal attack, as told by the relatives. He came with a restricted range of motion of the right upper limb. Since the patient was having hypertension and there was suspicion of stroke, so neurological opinion was made, but there was no neuro deficit. There was no history of any convulsions either. And they did the EEG, which was found to be normal. MRI didn't show any abnormality. So after 3 days of admission, orthopedic reference was made in view of increased shoulder pain and decreased range of motion. So patient limb attitude was in the adduction and internal rotation position. Movements were severely restricted. So the differential diagnosis in this patient can be a fracture, fracture dislocation, and less likely a stiff shoulder. So X-ray shoulder AP view was done. Axillary view was not possible because of the pain. So it showed a trough line sign, which is the thick, dense line seen on the medial aspect of the humeral head because of the glenoid impact. This is suggestive of posterior dislocation of the shoulder. Then there was a Hill-Sachs line, there is a light bulb sign, which shows the internal rotation of the shoulder. So both of these features show us this, it's suggestive of posterior dislocation of the shoulder. So for confirmation of the diagnosis, CT scan was done. CT scan was diagnostic of posterior dislocation along with the reverse Hill-Sachs lesion, and there was a partial LT fracture. So the plan was to do a closed reduction under anesthesia. Patient was taken under GA in a supine position in the OT. So the reduction technique used was the traction, counter traction was applied in a adductor position. Then arm was pushed laterally. There was followed by a forward push. This resulted in the relocation of the shoulder joint, but it was kept in an external rotation position as joint was dislocating in internal rotation of around 20 to 30 degree. So immobilization. So because of the absence of the abduction brace, stepping was done, which was starting from the medial aspect of the humerus, and which is rotated around the arm in the anti-clockwise direction in the right side, and was strapped to the back. A Gamgee roll was kept in between the trunk and the humerus. So this was the C-arm images immediately after the reduction before stepping. This is the AP view, and there is an axillary view showing the reduced shoulder. So after the stepping was applied, patient was shifted to the ward, and this X-ray was taken in the ward in the evening, showing a reduced shoulder. So the stepping was continued for a period of 4 weeks, and it was changed once at the end of 2 weeks under supervision. So stepping removed after 4 weeks, and this is the last X-ray which was taken. So rehab was started starting with the active assisted range of access and passive arm exercises. So the take-home points in this, there should be high index of suspicion for posterior dislocation in case of a syncope, even without major trauma. 50% of these patients are missed on X-ray. Stepping can be used in the absence of abduction brace, which is a cheaper option, and immobilization should be done for a period of 4 weeks. Thanks for your attention.